You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
Welcome back to part 2 of atrial fibrillation. In this episode, we'll go over electrical cardioversion, bleeding and stroke risk, ablation, left atrial appendage occlusion, and lifestyle measures. Let's start with electrical cardioversion. When cardioverting, the minimal effective energy should be employed initially to reduce the risk of myocardial damage, with upward titration as required. If the maximum energy level of the electrical cardioverter fails to terminate the anormal rhythm, repeated shocks at the same energy level are still worthwhile, as it can decrease the chest wall impedance and may consequently succeed. The only two situations where you are allowed to use a non-synchronized shock are ventricular fibrillation and rapid ventricular flutter. Synchronization refers to firing on the QRS complex. Firing on the ST segment or T wave may precipitate ventricular fibrillation. Pre-cardioversion use of ibutylide may enhance the success of cardiac conversion from AFib to normal sinus rhythm. Electrical cardioversion is contraindicated in digitalis-induced tachyarrhythmias because of the potential of inducing ventricular proarrhythmia. After successful cardioversion, anticoagulation should be continued for an additional 3 to 4 weeks because full recovery of atrial mechanical activity often lags behind the return of normal electrical function, giving rise to thrombus formation from blood stasis. What do the 2023 AFib guidelines say regarding electrical cardioversion? In patients with hemodynamic instability attributable to AFib, immediate electrical cardioversion should be performed to restore sinus rhythm. That's a class 1 recommendation. In patients with AFib who are hemodynamically stable, electrical cardioversion can be performed as an initial rhythm control strategy or after unsuccessful pharmacologic cardioversion, class 1. In patients with AFib undergoing electrical cardioversion, energy delivery should be confirmed to be synchronized to the QRS to reduce the risk of inducing VFib, class 1. For patients with AFib undergoing elective electrical cardioversion, the use of biphasic energy of at least 200 joules as the initial energy can be beneficial to improve success of initial electrical shock, class 2A. In patients with AFib undergoing elective cardioversion with longer duration of AFib or unsuccessful initial shock, optimization of the electrode vector, use of higher energy, and pretreatment with antiarrhythmic drugs can facilitate success of electrical cardioversion, class 2A. In patients with obesity and AFib, use of manual pressure augmentation and or further escalation of electrical energy may be beneficial to improve the success of electrical cardioversion, class 2B. So it's not made up putting your hand on a tissue box during these cardioversions. How about thromboembolism prevention in the setting of cardioversion? The 2023 AFib guidelines say, in patients with AFib duration of 48 hours or more, a 3-week duration of uninterrupted therapeutic anticoagulation or imaging evaluation to exclude intracardiac thrombus is recommended before elective cardioversion. In patients with AFib, that's class 1. In patients with AFib undergoing cardioversion, therapeutic anticoagulation should be established before cardioversion and continued for at least 4 weeks afterwards without interruption to prevent thromboembolism, class 1. In patients with AFib in whom cardioversion is deferred due to LAA thrombus detected on pre-cardioversion imaging, therapeutic anticoagulation should be instituted for at least 3 to 6 weeks, after which imaging should be repeated before cardioversion, class 1. In patients with AFib and previous LAAO, left atrial appendage occlusion, such as Watchman, who are not on anticoagulation, imaging evaluation to assess the adequacy of LAAO and exclude device-related thrombosis before cardioversion may be reasonable, class 2B. In patients with AFib and previous LAAO with residual leak, pericardioversion anticoagulation may be considered and continued thereafter, class 2B. In patients with reported AFib duration less than 48 hours, not in the setting of cardiac surgery, and who are not on anticoagulation, Pre-cardioversion imaging to exclude intracardiac thrombus may be considered in those who are at elevated thromboembolic risk, CHA2DS2-VASc score of 2 or higher, or equivalent, class 2B. And in patients with low thromboembolic risks, CHA2DS2-VASc 0 or 1 or equivalent, and AFib duration less than 12 hours, the benefit of pre-cardioversion imaging or pericardioversion anticoagulation is uncertain, given the low incidence of pericardioversion thromboembolic events in this population, class 2B. Now we'll move on from electrical cardioversion to bleeding and stroke in AFib. Compared to the CHA2DS2 score, which is CHF, hypertension, age of 75 or higher, diabetes, and stroke/TIA, CHA2DS2-VASc has several additions. Age is now 2 points if you are 75 or higher, 1 point if you are 65 to 74. Stroke or TIA or thromboembolism history is now 2 points instead of 1. And CHA2DS2-VASc adds vascular disease, which refers to prior MI, PAD, or aortic plaque, and also adds female sex. How exactly is each component defined in CHA2DS2-VASc? The 2023 AFib guidelines expanded the definition for some of these components relative to the initial CHA2DS2-VASc paper. The C for congestive heart failure is defined as the presence of signs and symptoms of either right or left ventricular failure. Right ventricular failure such as elevated central venous pressure, hepatomegaly, or dependent edema. Left ventricular failure signs such as exertional dyspnea, cough, fatigue, orthopnea, paroxysmal nocturnal dyspnea, cardiac enlargement, rouse, gallop rhythm, or pulmonary venous congestion, or both. This can be confirmed by non-invasive or invasive measurements demonstrating objective evidence of congestive heart failure. Next, the H for hypertension in CHA2DS2-VASc is defined as a resting blood pressure exceeding 140 millimeters of mercury systolic or exceeding 90 millimeters of mercury diastolic on at least 2 occasions, or requiring current antihypertensive pharmacologic treatment. Next, A in CHA2DS2-VASc is for age above or equal to 65 or 75. The D in diabetes, for diabetes, is defined as fasting plasma glucose level of 7 millimoles per liter or higher, which corresponds to 126 milligrams per deciliter or higher, or treatment with a hypoglycemic agent and or insulin. The S for stroke in CHA2DS2-VASc actually now refers to multiple kinds of thromboembolism. It can either be an ischemic stroke, a transient ischemic attack, a peripheral artery embolism, or a pulmonary embolism. The V for vascular disease in CHA2DS2-VASc can refer to coronary artery disease such as prior MI, angina pectoris, PCI or CABG, or peripheral vascular disease defined as the presence of any of the following: intermittent claudication, previous surgery or percutaneous intervention on the abdominal aorta or lower extremity vessels, abdominal or thoracic vascular surgery, arterial or venous thrombosis. And of course, the S is for female sex. So I hope by going over those definitions, you see how the 2023 AFib guidelines have really expanded the definition for some of these components relative to the initial CHA2DS2-VASc paper, and rightfully so, since these are risk factors for thrombosis. Hypertension counts as a point in both has bled and CHA2DS2-VASc. Prior stroke counts as a point in has bled and 2 points in CHA2DS2-VASc. Has bled should actually be more accurately called has bleed, HAASBLEAD. It stands for hypertension, abnormal liver function, abnormal kidney function, hence the 2 A's, stroke, bleeding events, labile INR, elderly, alcohol with 8 or more drinks per week, hence me adding the A beside the E in bled, and drugs such as aspirin, clopidogrel, or NSAIDs. Those are the components of the has bled score. If has bled is 3 or higher, that is a high risk of bleeding, 3.7%. So consider not anticoagulating. If CHA2DS2-VASc is 2 or higher, that is a moderate to high risk of ischemic stroke, 2.2%. So they should be on an anticoagulant. Remember that the things that count for 2 points on CHAS-VASc are stroke/TIA/thromboembolism and age more than 75 years. What exactly do these numbers correspond to in terms of stroke risk? A CHAS-VASc of 9 corresponds to a 15% annual stroke risk. A CHAS-VASc of 8 and 5 correspond to a 6.7% annual stroke risk, whereas 6 and 7 correspond to a 9.8% annual stroke risk. The ones from 4 to 1 are easy to remember because they are the same. 4 corresponds to a 4.0% annual stroke risk. A CHAS-VASc of 3 corresponds to a 3.2% annual stroke risk. CHAS-VASc of 2 corresponds to a 2.2% annual stroke risk. And a CHAS-VASc of 1 corresponds to a 1.3% annual stroke risk. What do the guidelines say about antithrombotic therapy and AFib? According to the 2023 ACC/AHA HRS guideline for the diagnosis and management of atrial fibrillation, for patients with AFib and an estimated annual thromboembolic risk of at least 2% per year, such as a CHAS-VASc score of at least 2 in men and at least 3 in women, anticoagulation is recommended to prevent stroke and systemic thromboembolism. The reason why we say or equivalent to CHAS-VASc score is because other scores can be used alongside CHAS-VASc in estimating the risks. For patients with AFib and an estimated annual thromboembolic risk of at least 1%, but less than 2% per year, equivalent to a CHAS-VASc score of 1 in men and 2 in women, anticoagulation is reasonable to prevent stroke and systemic thromboembolism, Class 2A. In patients with AFib who are candidates for anticoagulation and without an indication for antiplatelet therapy, aspirin either alone or in combination with clopidogrel as an alternative to anticoagulation is not recommended to reduce stroke risk. That's Class 3 harm. In patients with AFib without risk factors for stroke, aspirin monotherapy for prevention of thromboembolic events is of no benefit. That's Class 3, no benefit. And for patients with AFib, non-evidence doses of DOAC should be avoided to minimize risk of preventable thromboembolism or major bleeding and to improve survival. Class 3 harm. The 2023 AFib guidelines also include a really cool new section on what to do when a patient comes in with an alert of high atrial rate from a commercial watch or tracking device, which is very popular these days, without having a previous diagnosis of AFib. For patients with a device-detected atrial high rate episode, AHRE, lasting for at least 24 hours, and with a CHAS-VASc score of at least 2 or equivalent stroke risk by another score, it is reasonable to initiate oral anticoagulation within a shared decision-making framework that considers episode duration and individual patient risk. That's a Class 2A recommendation. For patients with device-detected atrial high rate episodes lasting between 5 minutes and 24 hours, in contrast to more than 24 hours, and with a CHAS-VASc score of at least 3 or equivalent stroke risk, it may be reasonable to initiate anticoagulation within a shared decision-making framework that considers episode duration and individual patient risk, Class 2B. Whereas patients with a device-detected atrial high rate episode less than 5 minutes and without another indication for oral anticoagulation should not receive oral anticoagulation. That's Class 3, no benefit. So basically, the cutoffs are 5 minutes and 24 hours for these atrial high rate episodes detected on commercial devices. Now we'll talk about valvular AFib. What exactly is valvular AFib? It refers to AFib with moderate to severe rheumatic mitral stenosis or a mechanical prosthetic valve. If you have valvular AFib, CHAS-VASc goes out the window and you have to start warfarin. Some people have proposed renaming valvular AFib to MARM AFib, M-A-R-M, meaning mechanical and rheumatic mitral valvular AFib, in order to not confuse it with other kinds of valvular disease. Recent trials have all allowed native valvular heart disease other than moderate and severe mitral stenosis and prosthetic heart valves to be included. The distinction between valvular and non-valvular AFib remains a matter of debate. with the 2023 AFib guidelines urging people to stop using the term valvular AFib, but they do not suggest a replacement classification. What do the guidelines say about antithrombotic therapy in MARM AFib or valvular AFib? According to the 2023 ACC-AHA HRS guideline for the diagnosis and management of atrial fibrillation, in patients with AFib who do not have a history of moderate to severe rheumatic mitral stenosis or a mechanical heart valve and who are candidates for anticoagulation, DOACs are recommended over warfarin to reduce the risk of mortality, stroke, systemic embolism, and ICH. Class 1. Now, other than MARM AFib, CHADS-VASc also goes out the window if AFib or aflutter happens in a patient with hypertrophic cardiomyopathy. An HCM patient who has AFib or aflutter automatically earns therapeutic anticoagulation regardless of what their CHADS-VASc score is. Cardiac amyloidosis and hyperthyroidism or thyrotoxicosis are other conditions where CHADS-VASc goes out the window. If you TE cardioversion an AFib patient whose CHADS-VASc is 0, you still have to give at least 1 month of oral therapeutic anticoagulation. The additional risk factors that increase the risk of stroke that are not included in CHADS-VASc are higher AFib burden or long duration, although this isn't exactly defined in the guidelines what higher or long refers to, persistent or permanent AFib compared to paroxysmal AFib, obesity defined as BMI of 30 kg per meter square or higher, hypertrophic cardiomyopathy, poorly controlled hypertension, chronic kidney disease with eGFR less than 45, proteinuria of more than 150 mg per 24 hours or equivalent, or enlarged LA volume. These are the additional risk factors that increase the risk of stroke not included in CHADS-VASc. Aspirin no longer has a role in stroke prevention in AFib. Also note that Child-Pugh Class C liver cirrhosis is a contraindication to using DOACs, and you have to use warfarin instead. Now, there are a lot of other messy situations when it comes to bleeding and AFib. What should you do if a patient with AFib develops intracranial hemorrhage? This broadly encompasses intraparenchymal or intracerebral hemorrhage, subarachnoid hemorrhage, subdural hemorrhage, and epidural hemorrhage. The 2023 AFib guidelines say, in patients with AFib and conditions associated with very high-risk thromboembolic events, more than 5% per year, such as rheumatic heart disease or a mechanical heart valve, that's MARM AFib, early resumption, that's 1 to 2 weeks, of anticoagulation after ICH is reasonable to reduce the risk of thromboembolic events. That's a Class 2A recommendation. Meanwhile, in patients with AFib and ICH, delayed, meaning 4 to 8 weeks, resumption of anticoagulation may be considered to balance the risk of thromboembolic and hemorrhagic complications after careful risk-benefit assessment. Class 2B. So, in other words, they're saying that for MARM and anything else that gives you more than 5% thromboembolic risk, 1 to 2 weeks is like a reasonable amount of time to wait, whereas in all other cases, 4 to 8 weeks is a reasonable time to wait after the intracranial hemorrhage. Okay. In patients with AFib and conditions associated with high-risk recurrent ICH, such as cerebral amyloid angiopathy, anticoagulation sparing strategies, such as Watchman placement, may be considered to reduce the risk of recurrent hemorrhage. That's a Class 2B indication. Another situation to know about is paraprocedural management of anticoagulants in AFib. In terms of how far ahead you have to discontinue DOACs before a high bleeding risk procedure, such as a left heart catheterization, it is 2 days beforehand for all DOACs, except if it is dabigatran in a patient with creatinine clearance of less than 50, then it's 4 days beforehand. Before a low bleeding risk procedure, it is 1 day beforehand for all DOACs, except if it's dabigatran in a patient with creatinine clearance less than 50, then it's 2 days beforehand. For warfarin, it is discontinued 5 days beforehand if you're trying to target an INR of less than 1.5, 2 to 4 days beforehand if you're trying to target an INR of less than 2. The 2023 AFib guidelines say in patients with AFib, excluding those with a recent stroke or TIA or a mechanical valve, and an oral anticoagulation with either warfarin or DOAC who are scheduled to undergo an invasive procedure or surgery, temporary cessation of oral anticoagulation without bridging anticoagulation is recommended. Class 1. In patients with AFib on warfarin anticoagulation and an annual predicted risk of thromboembolism of at least 5%, undergoing pacemaker or defibrillator implantation or generator change, continued anticoagulation is recommended in preference to interruption of warfarin and bridging anticoagulation with heparin due to the risk of pocket hematoma from heparin. Class 1. In patients with AFib with a CHA2DS2-VASc score of at least 2 or equivalent risk of stroke on DOAC anticoagulation and undergoing pacemaker or defibrillator implantation or generator change, either uninterrupted or interrupted DOAC is reasonable. Class 2A. In patients with AFib on DOAC scheduled to undergo an invasive procedure or surgery that cannot be performed safely on uninterrupted anticoagulation, the timing of interruption of DOAC should be guided by the specific agent, renal function, and the bleeding risk of the procedure. Class 1. In patients with AFib on DOAC that has been interrupted for an invasive procedure or surgery, in general, resumption of the anticoagulation the day after low bleeding risk surgery and between the evening of the second day and the evening of the third day after high bleeding risk surgery is reasonable, as long as hemostasis has been achieved and further bleeding is not anticipated. Class 2A. And in patients with AFib on warfarin anticoagulation who are undergoing surgeries or procedures for which they're holding warfarin, except in patients with mechanical valve or recent stroke or TIA, bridging anticoagulation with low molecular weight heparin should not be administered. Class 3, harm. Now let's move on to left atrial appendage occlusion and excision or exclusion by surgery. The 2023 AFib guidelines fortunately offer more clarity on left atrial appendage occlusion devices such as the Watchman. They say in patients with AFib, a moderate to high risk of stroke, CHA2DS2-VASc score of 2 or higher, and a contraindication to long-term oral anticoagulation due to a non-reversible cause, percutaneous left atrial appendage occlusion, or PLAAO, such as Watchman, is reasonable. That's a Class 2A indication. In patients with AFib and a moderate to high risk of stroke and a high risk of major bleeding on oral anticoagulation, percutaneous LAAO may be a reasonable alternative to oral anticoagulation based on patient preference, with careful consideration of procedural risk and understanding that the evidence for oral anticoagulation is more extensive. Class 2B. The situations where long-term anticoagulation are contraindicated are severe bleeding due to a non-reversible cause involving the gastrointestinal, pulmonary, or genitourinary systems, spontaneous intracranial or intraspinal bleeding due to a non-reversible cause, and serious bleeding related to recurrent falls when the cause of falls is not felt to be treatable. So situations where long-term anticoagulation are still reasonable are bleeding involving the GI, pulmonary, or GU systems that is treatable, bleeding related to isolated trauma, and bleeding related to procedural complications. Now, how about MAZE? Surgical MAZE is never prescribed as a standalone therapy. It is only recommended in patients who are undergoing cardiac surgery for another indication. The 2023 guidelines say, in patients with AFib undergoing cardiac surgery with a CHA2DS2-VASc score of 2 or higher or equivalent stroke risk, surgical LAA exclusion, in addition to continued anticoagulation, is indicated to reduce the risk of stroke and systemic embolism. That's a Class 1 indication. In patients with AFib undergoing cardiac surgery and LAA occlusion, a surgical technique resulting in absence of flow across the suture line and a stump of less than 1 centimeter as determined by intraoperative TEE should be used. Class 1. In patients with AFib undergoing cardiac surgery with CHA2DS2-VASc score of at least 2 or equivalent stroke risk, the benefit of surgical LAA exclusion in the absence of continued anticoagulation to reduce the risk of stroke and systemic embolism is uncertain. Class 2B. Now we'll move on to ablation of AFib. Initial AFib ablation techniques targeted sites of PACs at the origin within the pulmonary veins, the site of origin of AFib in many patients. But very few patients had sufficient PACs to serve as such a target, and ablation within the pulmonary veins can cause pulmonary vein stenosis. Subsequently, AFib ablation techniques shifted to electrical isolation of the pulmonary veins by creating a circumferential line of block encircling the venous ostia so as to prevent spread of impulses from the site of initiation to the vulnerable substrate in the left atrium. At high volume centers, single procedure success rates of AFib ablation are 60 to 75% in patients with paroxysmal AFib and 50% in patients with persistent AFib. Do not try to ablate patients who cannot be anticoagulated because ablation does not obviate the need for long-term oral anticoagulation. So, what do the 2023 AFib guidelines say about catheter ablation? In patients with symptomatic AFib, in whom antiarrhythmic drugs have been ineffective, contraindicated, not tolerated, or not preferred, and in whom continued rhythm control is desired, catheter ablation is useful to improve symptoms. That has a class 1 recommendation. In selected patients, generally younger with few comorbidities with symptomatic paroxysmal AFib, in whom rhythm control is desired, catheter ablation is useful as a first-line therapy to improve symptoms and reduce progression to persistent AFib, class 1. So note that that actually represents an upgrade from prior guidelines. They're allowing young patients with few comorbidities who have symptoms from AFib to do catheter ablation as first line if that is part of their goals of care. In patients other than younger with few comorbidities with symptomatic paroxysmal or persistent AFib who are being managed with a rhythm control strategy, catheter ablation as first line therapy can be useful to improve symptoms. This has a class 2A recommendation associated with it. So it's similar to the last one I just told you about, but that one was class 1 in the younger patients with fewer comorbidities, and this one is class 2A. Next, in patients with symptomatic or clinically significant atrial flutter, catheter ablation is useful for improving symptoms. In patients who are undergoing ablation for AFib, ablation of additional clinically significant supraventricular arrhythmias can be useful to reduce the likelihood of future arrhythmia, class 2A. In selected patients with asymptomatic or minimally symptomatic AFib, catheter ablation may be useful for reducing progression of AFib and its associated complications, class 2B. How about anticoagulation during and after AFib ablation? The 2023 AFib guidelines say in patients on warfarin who are undergoing catheter ablation of AFib, catheter ablation should be performed on uninterrupted therapeutic anticoagulation with a goal INR of 2.0 to 3.0, class 1. In patients on a DOAC who are undergoing catheter ablation of AFib, catheter ablation should be performed with either continuous or minimally uninterrupted oral anticoagulation, class 1. In patients who have undergone catheter ablation of AFib, oral anticoagulation should be continued for at least 3 months after the procedure with a longer duration determined by underlying risk, class 1. In patients who have undergone catheter ablation of AFib, continuation of longer-term oral anticoagulation should be dictated according to the patient's stroke risk, such as a CHA2DS2-VASc score of 2 or higher, class 1. Now, we should also know about the complications from ablation. Cardiac tamponade, pulmonary vein stenosis, and cerebral thromboembolism occur at a rate of 1% each as a complication of AFib ablation. If you have dyspnea after AFib ablation, think about the following. If the dyspnea occurs just days after, consider volume overload, atelectasis, recurrent atrial arrhythmia, cardiac tamponade, or phrenic nerve palsy. If the dyspnea is occurring months after the AFib ablation, consider pulmonary vein stenosis, recurrent atrial arrhythmia, and stiff left atrial syndrome. If you see fever or chills, esophageal symptoms, stroke, or GI bleed 2 to 4 weeks after ablation, suspect atrial esophageal fistula. If you suspect atrial esophageal fistula, avoid endoscopy as it might make it worse. You should do CT or MRI instead, and then go to surgery. We cannot finish our discussion on AFib without touching upon lifestyle measures. The 2023 AFib guidelines have a great emphasis on preventive and lifestyle measures, more so than the previous set of guidelines. They say that for patients with AFib, recommending caffeine abstention to prevent AFib episodes is of no benefit, although it may reduce symptoms in patients who report caffeine triggers or worsen AFib symptoms. Class 3, no benefit. This is a new change compared to the prior guidelines. In patients with AFib seeking a rhythm control strategy, they should minimize or eliminate alcohol consumption to reduce AFib recurrence and burden. Class 1. In individuals with AFib, moderate to vigorous exercise training to a target of 210 minutes per week is recommended to reduce AFib symptoms and burden, increase maintenance of sinus rhythm, increase functional capacity, and improve quality of life. Class 1. In patients with AFib who are overweight or obese with a BMI exceeding 27, weight loss is recommended with an ideal target of at least 10% weight loss to reduce AFib symptoms, burden, recurrence, and progression to persistent AFib. Class 1. Congratulations. That's all for part 2 of atrial fibrillation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.laaaو.com/meded.